Good morning, my name is Matthew Hickey, and today I'll be giving a presentation on do robotic or navigated TKA systems reduce revision rates enough to reduce overall costs? I have no disclosures to declare. Robotic and navigated TKA procedures have been introduced to improve component placement precision for the purpose of improving implant survivorship and other clinical outcomes. Although numerous studies have shown enhanced precision in placing components, adoption of technology assistance for TKA has been relatively slow, with an adoption of just 7% reported in 2014. One reason for this has been the difficulty in demonstrating the cost-effectiveness of implementing technology-assisted TKA systems. In this study, we aim to use a simulation approach to answer the following questions. First, can we determine the distribution of likely reductions in TKA revision rates attributable to technology assistance in an average U.S. patient population? And two, can we determine the cost-benefit relationship between technology-assisted TKA intervention and its subsequent impact on revision rates? In a previous study, we developed a method for creating large sets of simulated TKA patient populations with distributions of patient-specific factors, including age at index surgery, sex, and BMI, along with one surgeon-controlled factor, overall coronal alignment. Using this technique, we created a cohort of 10,000 simulated TKA patients with demographics matching the average U.S. patient population. For each patient, we simulated 2,000 TKA procedures using either a conventional or technology-assisted approach. Across the various simulated surgeries, we calculated the reduction in lifetime risk of revision due to technology-assisted intervention and the estimated savings or costs due to that intervention. For each patient in our simulation, we simulated 1,000 TKA surgeries, representing coronal alignment precisions reported for manual TKA procedures. Over these 1,000 surgeries, we estimated a patient-specific survival function and remaining life function based on age and sex to estimate the lifetime risk of revision. Next, we do an integration over the patient-specific survival function, evaluated at each percentile of the remaining life function to determine the lifetime risk of revision for that particular patient. This has the effect of weighting the probability of implant survival by the probability that the patient is still alive at a particular time post-index surgery. This process is then repeated using coronal alignment precisions reported for technology-assisted TKA. Next, we calculated the reduction in lifetime risk of revision by subtracting the lifetime risk of revision associated with the two techniques. This full simulation process is then repeated over the full cohort of 10,000 simulated TKA patients. We then conducted a simplified economic analysis with the goal of determining the net cost of using technology assistance in TKA per case when factoring in future savings by reductions in revision rates. We assumed an average cost of revision surgery to be $75,000 and an average added cost incurred by technology assistance to be $6,000 per case. We estimate the net cost per technology-assisted TKA case to be the added cost per technology-assisted intervention less the cost of revision surgery multiplied by the estimated reduction in lifetime risk of revision. After ordering patients in a cumulative distribution, our analysis showed that 90% of patients will achieve a reduction in lifetime risk of revision of 1.5% or less in an average U.S. TKA population. In contrast, we also found that use of technology assistance increases expected costs for all patients with a reduction in lifetime risk of revision under 8%. This work does have some important limitations. First, this simulation does not consider other possible reported benefits of technology-assisted TKA surgery, such as improved functional and pain outcome scores, which may justify its use on other grounds. Second, the study only assesses economic impacts assuming a single cost of revision surgery and cost of intervention, which may not reflect all practices or technology-assisted interventions. Based on these results, it appears that it would not be cost-effective to use technology assistance on more than a small fraction of the typical U.S. patient population if the goal is to reduce overall costs through reducing revision risk. Thank you, and I would like to thank the following groups for supporting this research.